Hello, this is Dr. Anas Yunus from Memorial Sloan Kettering Cancer Center in New York. Welcome to this educational activity of new evidence in frontline care of Hodgkin lymphoma and key concepts in integrating the latest evidence into practice. Joining me today in this panel discussion is Dr. Joseph Connors from BC Cancer Agency in Vancouver. Welcome, Joe.
I'm glad to be here, Anas.
And also Dr. Robert Chen from City of Hope in California on this panel. Robert, good to have you today.
Thank you for having me. I'm very happy to be here as well.
Excellent. So let's get started by exploring the current treatment landscape for Hodgkin lymphoma.
The following audio is part of a certified educational activity titled Treatment Evolution in Newly Diagnosed Hodgkin Lymphoma. A look at the evidence and implications for practice. Access the entire activity and complete the post-test at www.peerview.com/SFS. Downloadable slides and practice aids are also available.
So all of you know by now that the standard of care is rapidly changing. ABVD was the standard of care and probably still widely used, but it's been there for almost 40 years. And now we're starting to see new treatment strategies emerging that we'll talk about in the frontline setting. But not only the frontline setting, the salvage treatment is changing and post-autologous transplant treatment is changing. And over the last few years, we have 3 drugs approved for the treatment of Hodgkin lymphoma. Brentuximab vedotin initially approved for relapsed patients. Now we see it being used in the pre-transplant, post-transplant and maintenance setting, and now with the Echelon trial in the frontline setting. And then 2 checkpoint inhibitors were also recently approved, nivolumab and pembrolizumab, with slight variations on the label of indications. So before we move on, I'd like to briefly take a closer look at some of the newer therapies that we will be talking about, how they work, and why it is made sense to think of them as potential treatment options for Hodgkin lymphoma. So first, brentuximab vedotin, it's an old-fashioned naked antibody. It's conjugated to toxin. And in average, each antibody is conjugated to 3 to 4 toxic molecules, MMAE. And then this antibody-drug conjugate binds to CD30, get internalized, and then release the toxin, initially causing cell cycle arrest, and then after that, cell death. So the mechanism of action is very simple. It's delivery system of a toxic agent to the cancer cells. And we all know by now that in the phase 1 showed significant activity, which included both Hodgkin and anaplastic large cell lymphoma, but most patients were Hodgkin lymphoma in the phase 1. And the phase 2 pivotal trial led to the approval with a very impressive waterfall plot showing about 75% of the patients had some response and about 34% had a complete response rate. That was the initial approval strategy for brentuximab post-transplant failures with single agent once every 3 weeks, up to 16 doses, as we all know. The second approval was in maintenance setting, post-autologous transplant for patients which were high risk for relapse. They were randomized to placebo or single-agent brentuximab. The patients who received single-agent brentuximab did better in terms of progression-free survival after autologous transplant. This led to a second approval by the FDA. And then we got the checkpoint inhibitors. And we all know that T cells activation and inactivation is regulated by a set of receptors, and pembrolizumab and nivolumab are the drugs that target the inhibitory receptors. So when you block these inhibitory receptors, whether it's a PD-1 or CTLA-4, you end up having T cell activation. So now for Hodgkin lymphoma, we have 2 at least targets, CD30 and PD-L1, PD-1 interaction, because we learned over the last few years that Reed-Sternberg cells have an overexpression of PD-L1, PD-L2. So again, as you both know, that there was initial phase 1 trial that gave a very impressive signal in a small number of patients, but then the 2 pivotal trials were conducted that led to the approval of both nivolumab and pembrolizumab, and these 2 multi-arm phase 2 trials. Here we're looking at a scenario of a patient who relapsed after autologous transplant and after receiving brentuximab vedotin. So if you look at the outcome with pembrolizumab, 72% response rate, and nivolumab, 66%, almost identical responses, with lower complete response rate. In the next segment, we'll take a look at some of the evidence with these agents as therapy for newly diagnosed Hodgkin lymphoma, including studies that have led to recent approvals in this setting. Welcome back. As we saw earlier, the FDA has recently approved brentuximab vedotin in combination with chemotherapy for the management of newly diagnosed stage 3 and 4 Hodgkin lymphoma. And this was based on the recent phase 3 Echelon-1 study. Joe, why don't you walk us through this new data about Echelon-1?
So I'd be happy to do that, and I'll second your comment that this is an exciting time for Hodgkin lymphoma. After a long period, we have new agents with high levels of activity, making it logical to bring them through relapse settings and then earlier relapse settings and all the way to the front line. And that's specifically what we addressed in the Echelon-1 trial. The idea here was to conduct a straightforward experiment in which we took standard chemotherapy, ABVD, that we've used for decades, changed it by taking the bleomycin out and putting brentuximab in, and then conducted the experiment.
So why wouldn't combine ABVD with brentuximab? Why didn't we do like R-CHOP versus CHOP? Why did we have to take the bleo out?
Well, we briefly explored that. And it turned out that when one gives brentuximab and bleomycin at the same time, unacceptable levels of pulmonary toxicity occur. So it was a very important lesson to learn. And one needed to take out the bleomycin and put the brentuximab in to keep this all safe. The trial is a straightforward one. Half of the patients were assigned to standard ABVD and half to a regimen that we've called A-AVD. That's the one with the brentuximab brought in and the bleomycin taken out. Patients were planned to have 6 cycles of treatment. They were reassessed, as is increasingly common with PET scanning after 2 cycles, and there was an option for clinicians to switch to a different treatment if they were quite unsatisfied with what had happened, if the Duvel score was a 5. That was very seldom actually employed, but it was there. It didn't count as an event in the trial. And we went on and then compared the outcome after 6 cycles of treatment with each of the 2 regimens. This was a straightforward way to bring about an interpretation, but we had to wrestle with one specific aspect of the endpoint. We were using progression-free survival. It's obvious when progression occurs or death from any cause that those should be scored as an event. But as you can see in the lower examples on this slide, there's also the scenario where a patient reaches the end of treatment and there's been an unsatisfactory response. They have evidence of persistent disease shown by persistent PET scan positivity. In that case, the patient may not have experienced either a progression and they're still alive, but the treatment itself has been inadequate. The disease is still present. So we developed a careful set of criteria to identify that event in which it was a coupling of an abnormal PET scan and subsequent treatment. That way we were able to determine all of the situations in which the primary chemotherapy failed at its task of eliminating the Hodgkin lymphoma.
But a biopsy was not required, right, to confirm it? So.
It wasn't, and this speaks to a challenge in this situation because often the residual masses that are present are difficult to biopsy. And what sample one might take could easily be simply a missed diagnosis. We thought the evidence was strong enough that when both the PET scan was positive, and we did use Duvel 3 through 5, but also it was acted upon. So there was the option there. If the clinician didn't believe it, then they just watched the patient and that was not scored as an event. It had to be acted upon. It was the coupling of the positive PET scan and the intervention. That's a circumstance in which somebody, the primary clinician, has clearly decided the primary therapy failed. That we wanted to count as an event. A small number of events were scored that way as an event, and these were combined then, so progression, death, or treatment because of persistent PET positivity. And we can look then to see if this was an example of the kind of patient that this is appropriate for. So on this slide, we are comparing the characteristics of the patients that are typical of advanced stage Hodgkin lymphoma. And I'll point out that 15% of them were over the age of 60. And these were from regions from around the world. The study was conducted at over 200 centers. It was an enormous effort, enrolling 1,300 patients. We also can note that this was advanced stage disease. As you can see glancing down those columns, these patients had poor performance status occasionally, B symptoms frequently, bone marrow involvement, almost a quarter of the patients, multiple sites of extranodal disease. These were patients with high tumor burden Hodgkin lymphoma, the very patients that we want to find a better treatment for. The primary goal of the trial was to see if there was a difference in the well-defined endpoint, looking at the modified progression-free survival, the signal that the primary therapy had failed. And there was a clear-cut, statistically significant, and I think clinically relevant difference, with 77% of the patients sustaining their freedom from progression at 2 years on the standard arm, boosted up to 82% on the experimental arm. That 5% difference means that approximately a quarter of the patients who would have experienced a failure of their primary therapy with the standard treatment were permitted to avoid that with the experimental treatment. I think, as I said, a clinically relevant step forward in the treatment of advanced stage Hodgkin lymphoma.
Let me ask Robert, so what do you think of these results, Robert, the difference? Did this surprise you? Were you hoping to see better differences, or this is good enough for you?
Well, I mean, it is a positive result, statistically significant result. Now, was I surprised that it wasn't higher? Based on my own practice and the patient we enrolled, we had thought maybe the results would be more magnified in terms of the positive response. But when we look at the subset of patients, and I think future analysis will show that it also kind of depends on the risk factor the patients have, who can benefit a little bit more from other people. So yeah, I mean, I think overall I would call this moderate improvement, and certainly you can select for patient with even better improvement.
Joe, we did the phase 1 together, right? And the data was much better than this. Small number of patients, of course. Did this result surprise you? Were you hoping to see better response than this? Or?
I think that these are about as good as we could have hoped for. Remember that in the earlier experience, they were carefully selected patients for a phase 2 trial. We included about 20% of the patients had stage 2 disease. We didn't see anything like the high tumor burden that manifested in the patients that went on to this trial. And I think we're looking at the challenge of success. Nowadays, 3/4 of patients with Hodgkin lymphoma, regardless of marked high tumor burden, are cured of their disease. Shifting that upward is a major undertaking, hence 30 years of looking for something that does it. Certainly, I wish the difference were bigger and it would have been less worth debating, but at the end of the day, we did the experiment as carefully as we could. We had everything reviewed independently. We tried in every way we could to eliminate potential bias that would have altered the validity of the results, and it did work. We, as I said, we eliminated a quarter of the failures that would have occurred.
I think with some of the curable lymphomas, we may have reached a very difficult threshold where to make an improvement, it may become like a solid tumors, as we've been talking before. We will be seeing only increments by 5%, 7% with the new agents. I doubt that we'll be seeing 40% or 30% by adding drug X, because we're dealing with the resistant patients who are not responding to standard of care, and we couldn't make an indent, as you mentioned, in many years. The same thing for our CHOP. How many randomized trials failed by adding a drug X to? So this is clearly a positive data. I agree with you. Yeah.
And we do need to place it in context, and that is that we have to talk about the situation in which this was achieved against the price paid by the patient. So it's going to be important as we go on in our discussion to explore some of the aspects of the toxicity that was visited on people.
Okay.
In any kind of trial, you have the opportunity to explore the possibility that there are subsets of patients who had more or less advantage conferred by the experimental treatment. And this forest plot is important to me because it shows that there is no subgroup in which the ABVD appears to have been superior. So the standard arm didn't beat the experimental arm in any single subgroup. Most of the subgroups, you see them well shifted to the left, indicating the likelihood And remember, this is hypothesis generating, the likelihood that the subset being examined profited from receiving the experimental treatment. And so I take away from this collection of sub-analyses done here that we didn't see an area in which there was a clear failure of the intervention, and in multiple areas in which there appeared to be success. So this will help us as we think through how to construct future trials and what kinds of questions remain to be examined.
Does this guide your practice in these subsets, which patient you will choose? And I'll ask Rob also the same question in a minute.
Well, I try to be careful when interpreting subset analyses. Remember that as soon as you look at 20 things, you're going to start seeing some positive and some negative just at random. This is a way of rethinking some of your observations and gaining more insight into what went on. I don't think it's an adequate guide to select patients definitely for or definitely against receiving the treatment.
For example, looking at the slide here, I hear some colleagues say, well, you know, for stage 3 it didn't work as well, so I'm not going to give it to patient with stage 3, I'll give it to stage 4. Is this a valid kind of assessment? Would you do that?
I'd be very careful of that. Remember, because we were analyzing at a particular point in time, we're only seeing the events that have had a chance to evolve. Patients with very high tumor burdens, with multiple extranodal sites, stage 4 disease, everything's going to happen faster. So you see the differences in those patients. Patients with lower tumor burdens get closer to being cured with their treatment, and then it takes longer for the events to unfold. That's just one reason to be careful about the subset analyses. Robert, what do you think?
Yeah.
So, I mean, I agree with you. I think the subset analysis does give us a hint and some clues as to who might benefit even more from the treatment. And I agree with you that the trial was done for all stage 3 and 4 patients, and it did show that 5% improvement in modified PFS. What I take away from this subset analysis is that patients with higher risk factors, for example, stage 4 disease, higher IPS scores, they benefit even more. So you can expect an even greater benefit, greater than the 5% for those patients.
So let me rephrase the question. Looking at the data and looking at the data in totality and this subset analysis, would there be a patient that you would say, no, I'm not going to give you this new treatment, even though it's approved? Would there any subset of patient that you think, well, it's maybe not worth it, I'll just stick with the ABVD? I don't know if this is a fair question.
I think it's fair. This is clinical practice. You have to make the best decision for the patient in front of you. The only patient in which I would be wary and concerned about proceeding would be the kind of patient where I was concerned about toxicity. And we're still to explore some of the aspects of toxicity, but we do know if you give 2 neuropathic agents in the same regimen, brentuximab and vinblastine, you will see more neurotoxicity. Some of my patients come into their treatment with nutritional compromise, pre-existing neurologic disease, situations in which I would be quite concerned about exaggerated toxicity. That might put me off and say I best stick with the standard I was using previously. But as far as thinking I can pick out a group that is automatically going to do better, I would be very wary of that. I'm going to wrap up my part of this conversation with a return to what did we manage to avoid? So if the treatment fails, the patient needs additional treatment. This brings with it all of the toxicity associated with those treatments. And so in this slide, you can see the comparison here of the folks who needed to have subsequent anti-cancer treatment. And as you can see, the marked difference is there in terms of systemic therapy. And as you know, when you're treating someone with advanced stage disease whose disease wasn't eradicated with primary therapy, you now need to consider using highly escalated toxicity, intervention with high-dose chemotherapy, autologous stem cell transplant, perhaps additional radiation therapy. All kinds of toxicity may come along with this. Every time we can avoid that, we can avoid the toxicity, we can avoid the cost, we can avoid the impact on the patient. And so measured, if you like, as a what did we manage to avoid for this patient, a different way of looking at what I think is the success of the trial.
Agreed.
I think I'm going to turn the discussion back over to you, Anas, but I'll finish up with a few comments about the way I'm using this information and would like to see it used for going into practical treatment of patients. And that has to do with the fact that after 3 decades or more of only achieving what I could with ABVD, I'm delighted to have the option of exploring a different approach that may help some of those patients avoid the cost, toxicity, and problems of having their disease persist despite their primary therapy. So to make it concrete, I think it's reasonable to consider using the experimental arm from Echelon 1 for patients with stage 3 or stage 4 type of Hodgkin lymphoma.
Excellent. Rob, back to, again, the subsets. Which subset would you favor more to use the new treatment AAVD? And then if you look at the slide here, I'm looking at the elderly patients, which is usually a very difficult group to treat. Would this be like your standard of care now for someone who's physically fit, 65-year-old person come to you? Is that what would you offer? Or what would you do?
I think so. As Joe commented, most of the subset analysis in this forest plot do fall on the left side. You do see that patients who are elderly, greater than 60 years old, the benefit may not be as strong. Now, but that has traditionally been a difficult population to treat because they don't tend to tolerate chemotherapy well. So when you're adding another agent on top of AVD, you might potentially increase the toxicity in those patients. But there are other ways around it. Another study which you do is in a sequential matter. So in that, for those really elderly patients, that might be a better approach. Again, from what I see out of this is that patients who have more risk factors, stage 4 disease, high IPS, definitely have more benefit. And more detailed substance analysis are coming. They're presenting at ASCO and also EHA, and that has to do, I think, some data concerning how managing toxicities, because you can see the benefit may be even better if you were able to manage toxicities well in those patients.
So tell us about toxicity, Rob, since you're talking now. So what are the most common side effects, and are they preventable?
So basically, let's talk about ABVD first. The typical side effect ABVD are neutropenia, constipation, vomiting. And remember that ABVD, the V is been blasting, so already patients have a side effect of peripheral neuropathy to begin with in that arm. Now, in the experimental arm, BV plus AVD, generally the side effects were not that much different than ABVD with the exception of neutropenia, febrile neutropenia, and peripheral neuropathy. So those were a little bit more exaggerated. But the trade-off is you also have less pulmonary events because you're not giving bleomycin. So you introduce newer toxicities, but you're able to take away some other toxicity as well.
How about neutropenia and neutropenic fever? This seems to be like, initially was problematic, but then it was mitigated by the introduction of growth factor support.
Yeah, so basically, when the trial was done, we found that it was about 21% risk of febrile neutropenia. When we talk about neutropenia, majority are grade 1 or 2, and generally you don't have to worry too much about it. But when you see 21% risk of febrile neutropenia, you have to act on it, because the ASCO guidelines recommend that you should give GCSF primary prophylaxis for risk of febrile neutropenia greater than 20%. So about 75% of patients were already enrolled, and then when they figured this out, the study then recommended that patients should be given GCSF primary prophylaxis. So in that setting, you can see the rate of neutropenia dropped in the experimental arm from 73% down to 35%, and in the control arm from 57% down to 21%. More importantly, the significant AE of febrile neutropenia, the 21% dropped down to 11% with the use of growth factor support.
As you know, we're all told that, and we say the same thing because you guys are the expert also too, that if you have neutropenia on day 14 of ABVD, you can treat through it. So is this different now for AAVD? You should not ignore it, and you should always use growth factor support. Is that what you're saying?
Yeah, basically, when the risk of febrile neutropenia is 21%, and that ends up with hospitalization, antibiotic use, potential future complications, I think that mandates the use of GCSF primary prophylaxis. So I wouldn't even wait till you saw the patient became neutropenic. I would just start at the get-go when you're giving AAVD.
How about neuropathy? Is this also a common side effect with this combination? You mentioned that earlier.
Yeah, so with ABVD, the control arm in the study, patient had about a 43% risk of developing treatment-emergent peripheral neuropathy. Majority were grade 1 or 2. In the experimental arm, that risk increased to 67%. But again, majority were grade 1 or 2. Now, we know that with the history of brentuximab and as a single agent, that this peripheral neuropathy can resolve over time. So in this study, at the time of the last follow-up, 67% of patients, so essentially 2/3, had either resolution or improvement by at least 1 grade of the peripheral neuropathy. And the lasting neuropathy, majority again were grade 1. So 67% of the remaining patients had only grade 1 neuropathy at the end. So we talked about the experimental arm with the brentuximab, there's more neuropathy and neutropenia. But again, we also have to highlight that because bleomycin was not used, there's less pulmonary events. So you see the pulmonary toxicity of interstitial lung disease drop from 7% down to 2% in the experimental arm.
So practical,
There's a subtlety to this business of neuropathy that we need to remember, and that is that grade 1 neurotoxicity is asymptomatic. So it's there. You can find it if you do a careful neurologic examination.
Right.
My patients don't come back and complain to me about things they don't feel.
Right.
It's the grade 2 and 3. And what I found encouraging, Robert, was that with the passage of time, this is a toxicity that gradually goes away. Mm-hmm. So with care, proper dose reduction when it's necessary, and the likelihood that it will resolve with time, it's not something that puts my patients off from taking a treatment that might work better.
So Joe, walk us through like a patient, let's say you're treating and getting AAVD, now cycle 4, they're complaining of tinglings of your fingers and toes that is more noticeable than before. What would you do? Do you cut the BV? Do you space it out? What do you do?
This is the art of oncology. This is a situation in which you need to look holistically at what's going on with the patient. So for instance, if I have a patient who is a violin player, or perhaps a rapid typist, or a piano player, who is really dependent on very good motor function and minimization of neurotoxicity, I'll have a lower threshold for avoiding the potential for it to worsen. Another patient may be able to tolerate this quite well. But the bottom line here is that if I see a patient heading into trouble where it's going to interfere with life for them on a day-to-day basis, then I think I need to react. Fortunately, this is gradually cumulative toxicity and reversible toxicity. So by using appropriate judgment, for instance, I could reduce the dose, use a lower dose, and see if the neuropathy stabilizes or even better improves, I can carry on. If it keeps getting worse, I don't want to see a patient left with persistent, troublesome toxicity. And so at that point, I'll have to consider dropping the agent, remembering that I have 2 neuropathic agents here. So it now gets rather tricky to figure out, and I'll just do my best at judging, probably dropping the brentuximab first as the thing that's more likely to cause the deeper or more persistent toxicity. Right. And if necessary, dropping it from the latter courses of treatment. But I should already have seen much of the benefit that would come from the agent.
Okay. Rob, so another question for you. So now AAVD will be more frequently used. Let's say a patient get the AAVD and had a CR and then 6 months later progressing. Now you want to take that patient to a transplant. The patient progressed within 1 year of treatment. They have extranodal disease at high risk. Would you use brentuximab maintenance after autologous transplant, knowing that this patient had a prior exposure to brentuximab? This comes up all the time.
So yeah, I think it depends on the response you have received with brentuximab the first time and the duration of response. So for me, anything that's longer than 6 months of remission duration, I think you can safely retreat with brentuximab, hoping for efficacy again in a retreatment setting. But anything less than 6 months, for me, that's basically considered like primary progressive almost, and I would not use the drug again. So if your patient was 7, 8 months or a year after that relapse with disease, I would consider you giving it again.
Joe, would you
Yeah,
do the same?
I have the same approach. I think if disease progresses while a person is taking an agent, that's outright evidence that that agent doesn't work. So a refractory patient, a patient with progression during treatment or very shortly thereafter, I usually use about 3 months. I wouldn't reuse the agent because I think it's failed. But any patient who has had a durable response, 3, 6, 12 months of response, then I'm happy to bring the agent back in because we do have some evidence that it will work a second time around. And again, you have to keep your eye on toxicity because of the potential cumulative toxicity, the neurotoxicity associated. Again, the art of oncology and the right balance for the right patient.
Right. So now we switch gears. Let's now talk about immune checkpoint inhibitors in frontline Hodgkin lymphoma. The next few slides, I will discuss the findings from the CheckMate 205 study. And more importantly, I will talk about what's called cohort D, which actually combines nivolumab with AVD in newly diagnosed patients with Hodgkin lymphoma. This is a phase 2 single-arm multi-center trial, 51 patients treated, initially with the window single-agent nivolumab for 2 cycles, and then add the nivo to AVD. But if you look at the waterfall plot, this is all patients, treated with the combination. It's very impressive. Everybody had some response. There's no progression on the treatment, with many patients achieving complete response, which we will get to this in a minute when we dissect the response for single-agent nivo versus the end of therapy for nivo plus AVD. But that's what you see on this slide. If you look at the response rate with single-agent nivo, which was used as a window, it's 67% response rate by investigator, 69% by independent review, with about 18% CR rate, which is exactly what we've seen in the relapse setting. Rob, what do you think of this? Why is we're not seeing a higher response rate when we moved it up front in untreated patients? Is this surprising to you?
It's a little bit surprising because one theory of this immune checkpoint inhibitor is that if you have a more immunocompetent host, the efficacy might be greater. But again, that's why we have to do trials. And clearly, this showed that, in this Windows study, that nivolumab in the frontline setting had about the same efficacy as in the relapse setting.
What's also interesting now, if you look at the far right of this slide, this is at the end of therapy. Now you combine nivolumab plus AVD, 6 cycles, and at the end of therapy. And if you look at the independent review, 84% response rate, 67% CR rate. How do you put this in context with the Echelon trial? Joe, first.
Well, there are some challenges here. We're still learning how to properly assess response rates after the checkpoint inhibitors have been used. These work by a different mechanism, by involving the immune system. And exactly how that will play out in terms of interpreting PET scans and the other measures that we use is still, we're still pretty early on the learning curve there.
But the overall response rate,
that should be a good reflection. I think that there is a challenge, a possibility, if you like, that not having all the agents present from the beginning achieves less. It does make some sense that that would happen. But again, this is exploratory data. This is a phase 2 trial of a modest number of patients from which we are learning enough to know where to go in the future, not a definitive answer to exactly what this combination can accomplish.
But that's how we make decisions to guide the next step, right? Rob, would this tell you that this is exciting, that I'm going to do a randomized trial against AAVD? This is like an interesting, does this guide the next step? How do you use this data? And I know I'm putting you on a spot here, but I'd be interested in your opinion.
Well, so first of all, I do agree with Joe that it's very hard for us to assess a true CR rate on patients who are getting checkpoint inhibitors. I mean, as you can see here, by investigator, they actually call the CR rate to be 80%. So that kind of tells us that the current criteria as we use to assess CR is not really adequate for immune checkpoint inhibitors. So if you're going to go to a randomized study comparing this with Echelon 1, that's one problem you have to work out. How do you assess for CR rate? And then what do you use? PFS, modified PFS, EFS, and then the question of the modified PSF of people not achieving a CR needing additional therapy, that's even more complicated with immunotherapy. So it does give us some hint, but I don't know if that data alone is enough for me to design a randomized phase 3 trial off the bat at this time. So for example, one thing when you talk about checkpoint inhibitor is the immune-related AEs. So on the prior trial, the single agent trial, patients that can develop grade 1 or 2 events, what are those? For example, they might come in with slight elevations in liver function tests. They might come with mild skin rash or, like 1-a-day diarrhea kind of symptom, but doesn't really interfere with their function. Those patients, you can continue treating with immunotherapy and just kind of monitor them. For people that have some more bothersome symptoms, for grade 2 toxicity, you can withhold the immunotherapy and then give them steroids to resolve the symptoms if the symptoms don't resolve by withholding therapy. Now, sometimes, very rarely though, in the pivotal trials, the rate of grade 3, 4 immune-related AE were less than 5%. So these happen very rarely, but can happen. And they happen quite often, they're serious. For example, diarrhea that's nonstop 5-6 times a day, or pulmonary infiltrates, shortness of breath, pneumonitis symptoms. Those patients definitely need to be hospitalized, discontinue immunotherapy, and start on high-dose corticosteroids. And when you start on high-dose corticosteroid, you have to then think about antimicrobial, antifungal prophylaxis, because those patients, if they're on these corticosteroid for long term, 4 weeks or greater, they can get opportunistic infections. So in those settings, you want to do some kind of prophylaxis to help them get through this.
Excellent. And I return to my comment about we're in exciting times for Hodgkin lymphoma, because you could look upon the CHASC now as saying we have a core of 3 drugs, AVD. They work very well. They accomplish a lot. And now we have 2 exciting agents to add to that. We have to try a number of different experiments, putting them together on top of the AVD, using them sequentially, perhaps the brentuximab during the AVD and maintenance nivolumab or pembrolizumab afterwards. All of these ought to be thought through, preliminary experience gained, and allow us to arrive. But I'm excited to think that perhaps there'll be a patient who can't take the brentuximab very well, but now they have the checkpoint inhibitor.
Right.
Or the other way about. At least we have something to add to the core of AVD.
Exactly. And now there's a lot of excitement about combining these 2 agents because there's no overlapping toxicities. There's high response rate of each single agent, and they seem to be combinable at full doses. Rob, you were involved in one of the initial trials combining checkpoint with BV alone as doublet with no chemotherapy in the pre-transplant setting. Can you walk us through this very quickly about what's the significance of this combination?
So yeah, basically this was a very exciting trial because it was a bridge to transplant trial without needing additional combination chemotherapy. So 2, I would say, non-cytotoxic agents together and giving primarily outpatient setting. As you can see, so my colleague, Dr. Herrera, presented this at the ASH meeting and showed that just with these 2 agents, the overall response rate was 83% and the CR rate of 62%. And this compares very, very favorably with what we historically can achieve with multi-agent chemotherapy regimens. And of course, if you're taking someone to transplant, you want them to be in the best shape heading to transplant too. Not only do you want them to be in a CR, you also want them to have no organ toxicities.
And as all of us know now, there's a randomized trial in a post-transplant setting comparing BV alone, which is one of the standard of cares, to BV plus nivolumab. This is ongoing, and I hope most of you are participating in this clinical trial. But given this significant response rate and CR rate for this doublet pre-transplant, I keep hearing about chemo-free regimens now for Hodgkin. Do you think we're close to chemo-free regimen for Hodgkin lymphoma, or this is like a hype? Where do you think we're heading now?
Well, this might be my opportunity to object to the term chemo-free. I like using targeted agents or perhaps non-specifically cytotoxic agents or something like that. But at any rate, I think, yes, this is the way to go. as you pointed out, there may be some genuine synergy between these agents. The chemotherapy backbone and the brentuximab cause the cells to be lysed. They break up into pieces. These are potentially immunogenic. And now if we can augment the immune response to take advantage of that induced immunogenicity, it may very well be that we'll see something that works considerably better out of the combination. So I would return to thinking this is an exciting aspect to explore.
So which patient population, Rob, would you test or evaluate this kind of chemo-free regimen or targeted doublet that doesn't contain chemotherapy?
So one obvious population is the patients that would not tolerate your traditional ABVD therapy well. So we know that the elderly patients, age 60 or higher, typically can take all 6 cycles of ABVD or AVD. So there is a study right now ongoing evaluating this combination in older patients who've been previously untreated. And this data could be very exciting. And that could be the first step in moving to a targeted agent approach upfront.
So I think we've seen some interesting evidence today. And what's clear is that we have new options in frontline Hodgkin lymphoma and opportunities to further integrate novel agents into our practice. So thank you again, Joe and Rob, for your insights. And thank you for joining us today.
Thanks very much, Anas. It's been fun.
Yeah, it was an excellent discussion. Thank you for having me.
We hope you found the activity informative and useful to your practice.
Thank you for listening. Download materials and complete the post-test for instant credit at www.peerview.com/SFS. This activity is supported by an educational grant from Seattle Genetics. This activity has been jointly provided by Medical Learning Institute Incorporated and PVI, Peerview Institute for Medical Education.